Retinal Screening Made Easy by Veronica Cohn-Graverson from the University of North Carolina at Chapel Hill. In recent years, we have witnessed a revolution in the way visual information is recorded, stored, displayed, and accessed. In the era of fast-paced technology, digital imaging is revolutionizing the medical world. Retinal imaging is one of the most used tools in ophthalmology, and currently many adapters and handheld devices allowing examination of the fundus are available. The objective of this video is to demonstrate how retinal imaging, like what you will see here, can be taken by using a smartphone and a non-contact indirect lens. It can be a 20, a 25, a 28, or a 30 diopter lens. I will illustrate that you can easily investigate the optic nerve and the macular area in different clinical scenarios. You can also assess tortuosity of the vasculature and peripheral lesions. The technique can be used at the clinic or any place you find suitable for a screening. The technique can also assist screening efforts in different medical systems, and with the advances of telemedicine, it can be a useful aid to prevent contemporary global health problems. To obtain retinal images, a patient should be fully dilated and lying in the supine position. The smartphone should be in video feature with its flash on. Holding the non-contact indirect lens in the dominant hand, the observer should then position the phone about 23 to 25 centimeters away from the eye using the non-dominant hand. The phone's flashlight should be parallel to the lens, and then exact position of the lens respect to the eye will vary depending on its power. In patients with cataracts, like in this case, it could be cumbersome to take a good quality image, but it's still possible to assess the posterior pole. In this immunosuppressed patient with leukemia, you can assess the posterior pole, and you can also detect infiltrates inferotemporally and perifoveally. In cases of vasculitis, you can also evaluate sheathing of the vessels. In this case of lupus retinopathy, you can easily assess the posterior pole and evaluate cotton wool spots and multi-layer retinal hemorrhages in 360 degrees in both eyes. The technique can also assist you when evaluating a baby to document retinal hemorrhages, as in this case with shaken baby syndrome. In post-traumatic Terson syndrome, a multi-layer peripapillar hemorrhage can be detected, as well as Verlin's edema or commotio retina. The activity of choroidal neovascularization can also be assessed, as in this case with multifocal choroiditis. But not only the posterior pole is important. You can ask the patient to change the position of their eye to enable a more thorough evaluation. For example, in multifocal central serous retinopathy, you can determine the extension of the serous retinal detachment, as well as fibrinous deposits or retinal scars location. In cases of rhegmatogenous retinal detachments, you can also identify the causative lesion and create a montage with the video images that you have taken. The final montage can be used for clinical documentation purposes, as you can see here. The advantages of this technique are its cost and portability. The quality of the images taken with your smartphone have a higher resolution and appear sharper than the compressed video sequences shown here. In conclusion, this is an easy and convenient examination technique that can be a useful tool in the ophthalmologist armamentarium.